Good afternoon. We're going to start right away because we are tight on time with a very busy agenda. I want to welcome everyone to Best of SWOG, where you're going to hear about some of our most exciting recent work, trials that are truly making a difference for our patients. In general, you're going to hear 8-minute presentations, allowing 4 minutes for questions. Please, please, please use the chat box for anything on your mind. And I do want to remind our speakers, some of whom have a lot of slides, that we're going to be fairly rigorous in enforcing our time limits to be fair to all the speakers. So without further ado, I'm going to jump into our first presentation. Dr. Megan Trivedi is going to talk about the breast cancer cohort in 1714, chemo-induced peripheral neuropathy. Thanks.
Great. Thank you so much for the introduction and for the invitation to speak at the Best of SWOG at ASCO. On behalf of my co-authors, I'll be presenting our abstract on chemotherapy-induced peripheral neuropathy due to paclitaxel versus docetaxel in patients with early-stage breast cancer receiving taxane therapy on SWOG S1714. Next slide. Chemotherapy-induced peripheral neuropathy, or CIPN, is a side effect of many anti-neoplastic agents. The taxanes paclitaxel and docetaxel are known to cause CIPN and are commonly used in early-stage breast cancer. CIPN most commonly presents with sensory symptoms such as numbness and tingling, but can also cause motor or autonomic symptoms. And there are limited options for prevention and treatment of CIPN, and the mainstay of management of CIPN is chemotherapy dose modification. But not only can the CIPN symptoms impact quality of life, but can also limit the ability to administer standard doses of chemotherapy, which may ultimately affect long-term outcomes like survival. As such, identifying and characterizing predictors of CIPN is essential in order to individualize patient care. In this context, S1714 was designed as a prospective observational cohort study of individuals with stage 1 through 3 lung, breast, and ovarian cancer undergoing treatment with a taxane-based chemotherapy regimen. Over a 3-year period in the study, we assessed neuropathy symptoms using multiple different measures, including patient-reported outcome measures such as the EORTC CIPN-20, clinician-assessed outcome measures such as the NCI-CTCAE, neurosensory testing with the NeuroPen and tuning fork, and functional testing with the timed get up and go. Additionally, we collected biospecimen samples and treatment modification data. So between March 2019 and November of 2021, the trial enrolled 1,336 patients. The primary objective of S1714 is to develop a clinical risk prediction model of taxane-induced peripheral neuropathy. If you can click the next slide. In this abstract, we're going to focus on the cohort of patients with breast cancer and report on the neuropathy assessments using the CIPN-20 and the NCI-CTCAE from weeks 4 through 24 from registration. Next slide. So this abstract includes 1,103 patients with early-stage breast cancer enrolled on S1714, receiving either paclitaxel or docetaxel-based regimen. We're going to report on the data through 24 weeks from registration, which encompasses the treatment period for these patients. The primary endpoint measure for CIPN in S1714 was the patient-reported CIPN-20. CIPN-20 consists of 3 subscores, the sensory, motor, and autonomic subscore, with each subscale reported on a scale of 0 to 100, with a higher score indicating worse symptom. In this study, we defined an increase of 8 points or more on the CIPN sensory subscale score as a clinically meaningful change. And this definition was based on multiple studies that indicate that patients with CIPN experience a 7 to 10 point increase in the CIPN-20 sensory subscale score. We also collected the clinician-assessed CTCAE for nervous system disorders, which includes the adverse events of peripheral sensory neuropathy and peripheral motor neuropathy. As we know, the CTCAE is graded on a scale of 0 to 5, and we defined for the purposes of this study an increase in the CTCAE grade by 1 or more as clinically meaningful. There are limited prospective studies that describe the differences in CIPN symptoms between paclitaxel and docetaxel. Therefore, there was a planned analysis of paclitaxel versus docetaxel as a predictor of CIPN based on our prior work. At San Antonio Breast Cancer Symposium in 2022, we reported our findings on the incidence of CIPN as measured by the CIPN-20 and the CTCAE for peripheral sensory neuropathy in this breast cancer cohort. And we found that at 24 weeks, nearly 45% of patients with breast cancer receiving a taxane experienced a clinically meaningful CIPN. And now we seek to examine the differences in the CIPN symptoms between those who received paclitaxel versus docetaxel. Chi-square and Fisher tests were used for baseline comparisons, and logistic regression was used for multivariable analyses. Adjustments were made for the significantly different baseline characteristics between the groups. Next slide. This was a diverse cohort of mostly women. If you can click again. When comparing the baseline characteristics between the paclitaxel and docetaxel groups, there were significant differences in median age, race with white versus non-white, and a performance status of 0 versus 1 or more, and a diagnosis of diabetes. At baseline, there were no significant differences in neuropathy assessments between the two groups when using the patient-reported CIPN-20 sensory and motor subscores, or when using the clinician-assessed CTCAE grading for peripheral sensory and peripheral motor neuropathy. Next slide. So here are the results. So using the primary endpoint measure of an 8-point or higher increase in the CIPN-20 sensory subscore as the definition of clinically meaningful neuropathy, we compared those who received docetaxel, as shown in orange, to those receiving paclitaxel, which is shown in blue here. We found that there were significantly higher percentages of patients experiencing sensory neuropathy within the paclitaxel cohort compared to the docetaxel cohort. Of note, the p-values for all of the comparisons derived from the multivariable analyses were adjusted for age, race, diabetes, performance status, and baseline score. Next slide. When looking at the mean change in the CIPN-20 sensory subscore compared to baseline, the increase in sensory subscore for the paclitaxel cohort was significantly higher than the docetaxel cohort at all time points. With respect to the mean CIPN-20 motor subscore, the absolute increases were lower than the increases that were seen in the sensory subscore for both cohorts. And there was no significant difference in the mean change in the CIPN-20 motor subscore from baseline between the paclitaxel and docetaxel groups. Next slide. Using the clinician-assessed CTCAE for peripheral sensory neuropathy, the percentage of patients with a 1 grade or higher increase compared to baseline was significantly higher in the paclitaxel cohort compared to the docetaxel cohort at all time points. This is consistent with the findings seen using the CIPN-20 sensory subscore. Next slide. Finally, using the clinician-assessed CTCAE for peripheral motor neuropathy, the percentage of patients with a 1 grade or more increase compared to baseline was numerically higher in the paclitaxel cohort compared to the docetaxel cohort, but was only statistically significant at weeks 4 and 8. Again, we see that the absolute values of percentage of patients with a 1+ grade change or higher are less than what we saw with the peripheral sensory neuropathy. Next slide. So in conclusion, in this diverse cohort of predominantly female patients with breast cancer, sensory and motor CIPN symptoms were present and persistent in patients both with paclitaxel and docetaxel through 24 weeks. Sensory symptoms were more common than the motor CIPN symptoms. Using both the patient-reported CIPN-20 and the clinician-assessed CTCAE, the sensory symptoms were more severe in patients receiving paclitaxel at almost every time point through the 24 weeks from registration. Follow-up at 52, 104, and 156 weeks will better characterize the long-term trajectory of CIPN symptoms and the differences in symptoms between paclitaxel and docetaxel. We plan to further investigate the impact of the dosing frequency of the taxane and dose modifications on CIPN. Using the biospecimens that were collected in S1714, there are ongoing biomarker analyses to try to identify predictors of CIPN. Ultimately, the goal of this work is to be able to apply the findings to make individualized treatment decisions for our patients in order to optimize the outcomes and minimize the treatment-related toxicity. One more click. I want to acknowledge funding support from the NCI and the Hope Foundation, and thank you to all of the institutions and patients who participated in this study.
Great, thank you so much. Again, I'll encourage people to put questions in chat. In the meantime, any idea how the lung and ovarian cohorts are doing?
So it's a great question. We, again, enrolled about 1,300 patients and over 90% were breast cancer. So we still have to do some additional analyses on the lung and ovarian cohorts, which were much smaller.
And I'll ask another, do you feel fairly confident the biomarker analysis will truly allow prediction and/or prevention of the neuropathy?
Right. So I think the hope is that we can, better understand what the underlying mechanism for developing neuropathy is. I think a lot of the preliminary work suggests that different agents cause the neuropathy in different ways. Our hope is that the biomarkers will help enhance this clinical risk prediction model that we're building as part of S1714. So hopefully putting all of these pieces together will, again, just help us identify the patients that are at highest risk for developing neuropathy and allow us to individualize treatment. If we are able to identify biomarkers that better understand the underlying mechanism or pathophysiology of CIPN, hopefully we can help create targeted treatments as well.
Well, just perfect. Thank you so much for presenting. Next, I'll introduce Dr. Amir Goldkorn, who will be talking about the prognostic value of circulating tumor cell counts in metastatic hormone-sensitive prostate cancer from S1216.
Thank you very much, Dr. Blanke. Can you hear me okay? Excellent. And thank you all for the opportunity to share this work with you on behalf of my co-authors and colleagues in the GU committee. This was abstract 5080 at ASCO, baseline circulating tumor cells or CTC count as a prognostic marker of overall survival in metastatic hormone-sensitive prostate cancer. There were results from the SWOG S1216 trial, which was a phase 3 randomized trial of androgen deprivation plus orteronel, which is a CYP17 androgen synthesis inhibitor, versus bicalutamide, an anti-androgen. Next slide, please. So just a little bit of background on CTC counts as a biomarker in prostate cancer. So the need is definitely there in metastatic hormone-sensitive prostate cancer, patients, men newly presenting with metastatic disease. There's really been a proliferation of intensified treatment combinations that we've been using up front, comprised of androgen deprivation therapy, chemotherapy, androgen receptor pathway inhibitors, and even radiotherapy. And so effective biomarkers are needed to select poor prognosis patients for new trials. Liquid biopsies, you can imagine, is an attractive approach in this setting where patients have metastatic disease and we may not always have new tissue to profile on hand. So there have been a lot of studies looking at CTCs, circulating tumor DNA, which are non-invasive and repeatable. And CTC count using the FDA-cleared cell search platform has been extensively validated in metastatic castrate-resistant prostate cancer, the more advanced disease for patients who have already progressed on hormonal therapies. And I've shared some of those results from several trials, including our own done within SWOG that have shown the prognostic value of CTC count taken upfront in patients with castrate-resistant disease. Next slide, please. But what about metastatic hormone-sensitive prostate cancer? There is some preliminary evidence that CTC count is also prognostic in that setting, prognostic of PSA response after start of treatment, prognostic of progression-free survival. Mostly smaller studies with more heterogeneous patient populations. Some has actually predated the current era where we use these more intensified combinations up front. We did a study in SWOG S1216, this phase 3 trial, where we've already previously reported some of the preliminary data. We showed that baseline CTC count was prognostic of PSA response, but when the patients went on hormonal therapy, and also progression-free survival. You could see there in the left panel, if you see the dark taller bar, there was an odds ratio of nearly 9-fold likelihood of complete response to hormonal therapy in men who had no CTCs, 0 CTCs detected at baseline versus men who had 5 or more CTCs. And similarly on the right side, Men who had undetectable CTCs at baseline, only 40% of them progressed after 2 years on therapy, whereas men who had 5 or more CTCs, nearly 3/4 of them progressed by 2 years. So the signal was definitely there. And we now are able to report on the prognostic value with regard to overall survival. Next, please. So briefly, the design of SWOG S1216, the trial is a phase 3 randomized trial for men first presenting with hormone-sensitive metastatic prostate cancer. The PI is Dr. Neeraj Agarwal, University of Utah. The treatment arms are listed there for you. It's androgen deprivation plus either the standard bicalutamide at the time or orteronel, which was a CYP17 inhibitor similar to abiraterone, which we use in our patients. The trial opened back in 2013, closed by 2017, enrolled ultimately over 1,300 patients. The primary endpoint was overall survival, and unfortunately not quite met. This was reported last year in JCO. Both treatment arms actually did quite well, even the bicalutamide arm, due to the multiple subsequent therapies that are now available once the patients progress on study. But there were several secondary endpoints. And we'll focus here on the correlative studies, which included the liquid biopsy studies that were integrated into the trial. And so we collected CTC counts at baseline and in a subset of patients at progression. We also collected matched plasma cell-free DNA analysis, which will be discussed another day. That's still ongoing. Next slide, please. So the results. Here's what the cohort looked like. On the left, you have the consort diagram there with those 1,300 patients randomized. Now, CTC collection actually began after the trial began. There were still about 795 patients left to accrue. Of those, we collected samples in 523 and had 503 baseline samples available to analyze for this study. Of those 503, 61 patients, we actually had matched samples that we could draw at progression once they progressed to castrate-resistant disease on these hormonal therapies. And there were another 32 patients where we collected progression samples where we didn't have the baseline. So a total of 93 progression and those 503 baselines. If you look on the right in the table, on the right-hand side of the table, you see the patients with the CTC analysis, 503 patients. Quite representative of the overall cohort, which you see on the left, the entire cohort there. It's just broken down by the arms, your treatment arms. So in terms of baseline characteristics, they were representative. And what did those CTC counts look like? Okay, so at bottom, you see that we detected 0 CTCs in about 2/3 of patients at baseline, 1 to 4 CTCs in 21%, and 5 or more CTCs in about 12% of patients. Next, please. So getting straight to the punchline here, this is the overall survival data with baseline CTC counts. You see on the left there that there was a very clear separation of KM survival curves based on those baseline CTC counts. Men with 0 CTC counts at the top in blue, and then men with 1 to 4 baseline CTCs and 5 or more at the bottom in green. And I've given you the median overall survivals there at the bottom. 0 CTCs at baseline, still not reached to date, actually. We're about 7 or more years of follow-up. Men with 1 to 4 CTCs at baseline had a median survival of 56 months, and men with 5 or more CTCs only 27.9 months. So pretty stark difference, and we've listed for you also there the hazard ratios for risks of death in men with 1 to 4 or 5 or more CTCs relative to no CTCs. And those trends were quite similar when we broke it down by treatment arms, as you see on the right there. Next slide, please. Now, getting back to the response to initial treatment, this was PSA response and the PSA drop when they were started on hormonal therapies. Again, split, as you see on the left there, by men with 0 CTCs at baseline, in the middle, 1 to 4 CTCs, and on the right, 5 or more CTCs. And as you can see, the men with 0 CTCs at baseline, the majority of them actually experienced a complete response. That's the blue portion of the bars. Less so in men with 1 to 4. And you go over to the right, men with 5 or more CTCs, actually the majority were the gray portions of the bar, meaning they had no response at all to the start of hormonal therapy. And kind of broke down the numbers for you there on the right. basically that men with 5 or more CTCs were statistically significantly much less likely to experience a partial or complete response than men with no CTCs. Next slide, please. Looking at baseline CTC count and progression-free survival, again, the trends separated with statistical significance here as well, as you'd expect, with 0 CTCs doing much, much better, progression-free survival of about 5 years, men with 1 to 4 CTCs only about 20 months before they progressed on therapy, and men with 5 or more just under a year before they progressed on therapy. And again, no major difference by treatment arms, as you can see on the right there. Next. Now let's look briefly at the CTC counts from those men where we could get those progression samples. That is, once they progressed on therapy in the trial, we drew their blood again. And as you see on the left there, we separated them out by men who had fewer than 5 CTCs versus 5 or more CTCs per sample at progression, and clearly a strong separation of median overall survival, of survival curves there as well. Median overall survival nearly 42 months in men who had fewer than 5 CTCs, and only 15 months in men with 5 or more CTCs. And this was kind of interesting on the right here. Now, we only had 61 men where we actually had matched samples between baseline and when they progressed on therapy. But if you look at those on this table on the right, if you look at men who had 0 or even 1 to 4 CTCs at baseline, a large majority of them, 79%, 71%, still had fewer than 5 CTCs at progression. And conversely, in those few men who had 5 or more CTCs at baseline, 70% of those actually had 5 or more CTCs at progression as well. And this was statistically significant, these trends, using the Spearman's correlation statistic. And so, interestingly, having high or low CTC count at presentation with newly presenting metastatic hormone-sensitive disease also correlated with having the same high or low CTC counts after all this treatment when one progressed to castrate-resistant disease. Next. And so the conclusions in this large phase 3 clinical trial for men initiating therapy for metastatic hormone-sensitive prostate cancer, the baseline CTC count was highly prognostic of overall survival, as well as PSA response and progression-free survival. This robust association held despite years of subsequent therapies for disease progression. And as I noted, progression CTC counts mirrored the baseline, suggesting that there's some underlying aggressive biology in this subset of patients, which actually could be identified upfront and seems to continue after progression on treatment. So it's not just that they're treatment emergent aggressive disease phenotypes, but actually things that we can identify upfront, which kind of stay with these subsets of patients. And so in conclusion, men presenting with metastatic hormone-sensitive prostate cancer, baseline CTC count may be a valuable non-invasive biomarker to select poor prognosis patients for newer therapies and clinical trials. With that, I'd just like to thank everyone who participated, all of our co-authors and colleagues in the GU committee at SWOG, and of course, all our patients who participated in the study.
Thanks. That was lovely. I think we have time for one question, which looks like it's going to be me. So obviously, I'm a believer in offering clinical trials to patients expected to do poorly. But my question for you is there any evidence right now that selecting these patients out actually benefits them?
Yeah, so right now, we just have very few really good prognostic measures by which we can select them. So in some of the trials that were done in metastatic hormone-sensitive prostate cancer, we try to stratify men who are deemed to be high volume or high risk disease from men who were lower volume or low risk disease. But those stratifications didn't necessarily always correlate with having a response to therapy or not. And so we need to come up with additional new prognostic measures, preferably non-invasive ones, that can help us select those men. It's not something that's currently done in this disease setting, but as more and more intensified combination therapies are tested in new trials, we do believe it would be valuable to have a measure that would help us pick out those men who truly may derive benefit despite the potential additional toxicities of new therapies. So that's the direction that we're taking this.
Perfect. Thanks. And now it gives me great pleasure to introduce Dr. Seth Lerner, our new GU chair, at least in 3 days. Dr. Lerner will be talking about S1011, a comparison of standard versus extended lymphadenectomy in patients with bladder cancer. Dr. Lerner?
Thank you, Dr. Blanke. This trial tested a long-held assumption that removing more lymph nodes in the primary and secondary lymph node drainage of the bladder at the time of a cystectomy done for curable muscle-invasive cancer was associated with better outcomes and a better curative potential. Also in context, though, there had been at least 4 randomized trials, 2 in endometrial, 1 in pancreatic, and 1 in gastric, that tested this question about removing more lymph nodes or a more extensive lymphadenectomy. And all of them failed to show a benefit. And the gastric trial actually showed that there was higher morbidity associated with this. So we tested this hypothesis in this clinical trial that I'll describe here. Next slide, please. The primary objective was to compare disease-free survival in patients undergoing a cystectomy for curative intent. Predominant urothelial mixed histology was allowed, but under 50%. And the question was an extended node dissection, and I'll show you what that is shortly, was associated with improved disease-free survival, which we defined as the first documentation of relapse or recurrence or death due to any cause. We had a number of pre-specified secondary objectives, and I'll be reporting on these shortly. Next slide, please. So this is the trial design. Again, patients with muscle-invasive T2 through T4A undergoing a radical cystectomy. We allowed neoadjuvant chemotherapy as it had been well established in SWOG 8710, as well as another phase 3 trial done predominantly in the UK and Europe, that this was associated with better outcomes compared to cystectomy alone. We stratified by the type of chemotherapy they got, cisplatin, which would be the standard of care, versus carboplatin versus other versus none, clinical stage, organ confined versus non-organ confined, and performance status. This was an intraoperative randomization, so surgeons were required to explore and determine the absence or prove the absence of lymph node metastasis in the extended template, and then they were either randomized to extended or standard only. Postoperatively, if patients had locally advanced disease, they were eligible for adjuvant chemotherapy. We encouraged it, but did not require it. Advance, please. So these are the statistical assumptions. We reviewed trials at the time, actually cohort studies at the time of about 8,000 patients, and established the baseline 55% 3-year DFS in the standard arm. And we had 85% power to detect a 10 to 12% improvement in 3-year DFS in the extended arm. We didn't make that any tighter because this would have been a much larger study that at the time we didn't think we could carry off. But this resulted in a sample size of 564 eligible patients and a total accrual target of 620. Next slide, please. So this is the consort diagram. We registered 658, intraoperatively randomized 618, and there were a handful of ineligible patients in each of those arms, resulting in an intent to treat analysis of 300 patients in the standard arm, 292 in the extended arm, and a few patients in the standard arm did end up getting extended node dissections, and these were removed from the safety cohort. Median follow-up is 6 years, very mature, and within a time frame when you would expect to see the overwhelming majority of progression events and deaths due to bladder cancer. Next slide. So these are the pre-randomization clinical covariates. You can advance. I've got this is a distribution of patients that's very typical of cystectomy series. The majority of patients are clinically organ confined. About 25% had hydronephrosis, 12% had variant histology. I think if you advance, I've got some things highlighted here. So just click. There you go. So about 57% of patients had a standard of care neoadjuvant chemotherapy. Click, please. And 87% of those had cisplatin-based chemotherapy. No one had reported numbers like this before in any previous study. So this multidisciplinary group really was following level 1 evidence at the time. Next slide, please. So this is the pathologic tumor and node stage. About 20% of patients had no residual cancer. And remember, some of them got neoadjuvant chemotherapy, where we would expect up to about 35 to 40% to be PT0N0. Next, just advance, please. About 24% in the standard arm, 26% in the extended arm had positive nodes. Again, this is kind of what we would expect from other studies, and you can advance through the next two. And then the next one. So we would expect only, sorry, if you'll go back, we would expect only N3 disease, which is common iliac, to be in the extended template. Those 4 patients in the standard arm got an extended node dissection despite being randomized to standard. Next slide. This is the pathologic node status, and we would expect to see a much higher number of positive nodes in the extended arm because we're removing more lymph node bearing tissue. You can just advance through all of this, and the estimated blood loss, sorry, was similar between the 2 arms. So we did not show any difference in disease-free survival. You can see that these curves are overlapping, very long-term mature follow-up. Next slide. And we also didn't see a difference in overall survival. So it's quite clear that the extended node dissection was not associated with an improvement in disease-free or overall survival. Next slide, please. You can advance. Okay, so if you look at disease-free survival and comparing the 2 arms with the pre-specified stratification factors in the top and pathologic stage in the bottom, you can see that there was no difference in outcome for DFS with any of these pre-specified factors. Advance, please. The only exception, and this is hypothesis generating, that patients with non-organ confined but node negative cancer may derive a benefit from a more extensive node dissection, but this is, again, hypothesis testing. Next slide, please. We saw something very similar with the OS data. I'm not showing that for the sake of time. So this is the adverse event comparison, and this is regardless of attribution to the surgery or to the node dissection. This is all of the grade 3, grade 4 adverse events that were recorded. We see a slightly higher incidence of sepsis in the extended arm, a slightly higher rate of VTE events, and you can advance. The surprising thing was that there was a higher mortality risk at both 30-day and 90 days in the extended arm. These numbers are about, they're in line with what's been reported in the literature previously. Some of these events were due to progression, and in the manuscript we'll do a very detailed analysis of all of the causes of mortality within the 90 days. Next slide. So in conclusion, patients undergoing cystectomy in an extended node dissection had a higher node yield, which we would expect, but very similar pathologic tumor stage. The extended node dissection, we saw a higher median number of positive nodes among node-positive patients. This has been reported previously, again, because we're removing more lymph node metastasis and identifying those patients with disease outside the true pelvis. No indication of a benefit of DFS or OS in the extended arm. And as we saw, there was an association of higher morbidity and higher perioperative mortality within 90 days in the extended arm. I didn't present this, but there's a similar trial that was conducted in Germany led by Jürgen Geschwend. It's been published previously. Slightly different design, but very similar outcome with no benefit. And I think these 2 trials together really established that the standard of care is a bilateral standard lymph node dissection for patients with curable predominant urothelial muscle invasive bladder cancer. Thank you.
Thanks so much, Dr. Lerner. I think you actually already anticipated my first question. With the gastric studies, the standard of surgery was so different, particularly in Asia, than it was in the US. My question is, would people internationally believe the SWOG results? And is everybody, even abroad, no longer doing extended?
Well, we just reported this a few weeks ago. So
fair enough.
But having said that, and talking to my surgical colleagues, a lot of them, quite frankly, were somewhat relieved to see the data so that they didn't have to keep doing an extended node dissection. We've done a really good job over the last 10 to 15 years of convincing urologic cancer surgeons that the proper way to do this was with an extended node dissection. One thing I didn't mention is our highest accruer, Sia Danishman. He and I trained with Don Skinner, and Don really was the big proponent of this. And for those of us disciples of this extended node dissection, to establish equipoise and randomize these patients was really remarkable. And this is why we do these trials, because to answer this important question. But I think it will be adopted globally now that we've got both a European-based trial and a North American-based trial.
Well, this is a major standard of care change, so congratulations.
Thank you.
All right, we are going to move on to Dr. Nagla Abdel Karim, who's going to be talking about S1929, the addition of talazoparib for patients with small cell lung cancer selected for SLFN11 expression. At least I hope we will.
Okay, perfect. Thank you so much for having me here today. On behalf of my co-authors and colleagues, I'm pleased to present to you today the data of S1929 phase 2 randomized study of maintenance atezolizumab versus atezolizumab plus talazoparib in patients with SLFN11 positive extensive stage small cell lung cancer. It's a SWOG study. Next. So, as we all know, high PARP expression in small cell lung cancer makes PARP1 inhibition a potential therapeutic target. Moreover, talazoparib has been shown to be the most potent PARP inhibitor in preclinical studies. And as a matter of fact, SLFN11 was found to correlate with improved clinical outcome in small cell lung cancer patients treated with PARP inhibitors. This makes S1929 as a study that not only includes the novel agent talazoparib, however, it includes also a predictive biomarker of SLFN11 that goes hand in hand with talazoparib. The study has been designed to select SLFN11 positive small cell lung cancer patients with extensive stage disease to be randomized to either Arm A talazoparib, Arm A atezolizumab standard of care versus Arm B of atezolizumab in combination with the PARP inhibitor talazoparib following the standard of care platinum etoposide and atezolizumab induction therapy. The hypothesis is that the addition of talazoparib to maintenance atezolizumab will improve progression-free survival in SLFN11 positive small cell lung cancer. Our primary endpoint is progression-free survival. Our secondary endpoint has been overall survival, overall response rate, and assessment of toxicities. The translational medicine objective is to bank specimens for future correlative studies. Next. SLFN11 has been noted in previous study to have a 50% prevalence in patients with small cell lung cancer. We predicted that 85% of the patients will have evaluable tissue and that 68% of the patients with positive results will be able to initiate maintenance therapy. Assuming median progression-free survival of 4 months in the control arm, a design with 90% power to detect a hazard ratio of 0.56 using a one-sided 0.1 level log rank would require 78 progression-free survival events. Accrual goal, we expected to screen 323 patients in order to achieve 84 eligible randomized patients. Interim analysis performed when 50% of the expected progression-free survival events observed. Our stratification factor included performance status and prior thoracic radiation therapy. 324 samples were submitted or resubmitted, where 204 samples were positive for SLFN11. That's 79%. So that's higher than the expected 50%, where 55 patients had a negative SLFN11 status, that's 21%, with median time to report the SLFN11 result of 7 days. Next. Our baseline demographics, as you see, were well balanced. Next. The primary objective of the study has been met. Patients who received atezolizumab and talazoparib had median progression-free survival of 4.2 months compared to 2.8 months in the atezolizumab arm. Hazard ratio of 0.7 with 80% confidence interval of 0.52 to 0.94 with p-value of 0.56. The median time to report the progression-free survival has been 5 months. Next. The overall survival data is premature. As I mentioned, the median follow-up time has been only 5 months, where patients who received atezolizumab and talazoparib had mild improvement in the median overall survival of 9.4 months compared to 8.5 months, with hazard ratio 1.17, 80% confidence interval between 0.8 to 1.71, with the p-value 0.3, statistically not significant. Next. Treatment-related hematologic toxicity were mainly grade 3 anemia, occurring in 19 patients, that's 37%. Thrombocytopenia grade 3 occurred in 9 patients, that's 17%, and 4 patients grade 4, that's 8%. Next. Non-hematologic toxicity were mainly transaminitis and hyperglycemia with rare grade 4 or 5 toxicities. Next. As a conclusion, S1929 met its primary endpoint, demonstrating that maintenance atezolizumab and talazoparib improved progression-free survival in SLFN11 positive patients with extensive stage small cell lung cancer. Hematologic toxicity was increased in the experimental arm as expected, mainly grade 3 anemia. This study demonstrated the feasibility of conducting biomarker-selected trials in small cell lung cancer, paving the way for future and further evaluation of novel therapies in selected small cell lung cancer populations. We are currently analyzing the association of SLFN11 expression levels in the clinical outcome. I'm very thankful to our patients and to CTAP and all our support team. Very acknowledgement for SWOG and all my co-authors and mentors. This has been a unique collaboration in making a biomarker-based approach study in small cell lung cancer feasible as a step towards selected approach therapy in small cell lung cancer in the future. Thank you.
Thank you so much. I can say BRCA, but I'm not sure I can bring myself to say Schleffen, but I congratulate you for pulling it off. So 2 questions for you. It feels like small cell has really lagged behind some of the recent breakthroughs in non-small cell lung cancer. Do you think we're on the edge of major new findings?
Absolutely, especially that we have, number one, the feasibility of having biomarker-driven studies. We had only 7 days to know the status of the patients who had SLFN11 positivity. So that's number one. It is feasible. It was basically applicable in small cell lung cancer. Everybody was very concerned that the biopsies there are limited, but basically we even had FNA evaluation that was acceptable. The second piece is also we have now more information about predictive biomarkers. In addition to SLFN11, we do have RNA-seq for the subtypes, and that also has a very useful link for future studies. In addition to that, basically more information to base more novel therapies in that category.
Fantastic. And you sort of anticipated my next question. And speaking of biomarker information, do we have enough to actually do a master lung in small cell rather than do individual biomarker-driven trials?
We still need more preliminary work to explore the predictive biomarkers in terms of having a map, like a lung map like study. But at least at this point, we have, the biomarkers and we have the subtypes. It seems to be reasonable that we can move towards that step and make it as a protocol that can take one arm at a time. So the more we explore newer novel therapies and newer predictive biomarkers, we can add additional arms and not just limited to the information that we have in 2023.
Fantastic. Well, again, thank you so much.
I just want to add also something very important, that this study actually was able to meet accrual and even maybe over accrue in only 2 years in spite of COVID. So
that is important information. Thank you. So we always say it, but this time I really mean it. Last and certainly not least, we have Dr. Alex Herrera, who will be talking to us about S1826, which was a Hodgkin's lymphoma trial that was just presented at the ASCO plenary session. Dr. Herrera?
Thank you so much for the opportunity to speak today. We're very excited to share the initial results from SWOG S1826 with you all on behalf of the co-authors and all the many participating North American investigators all across the NCTN. So to start, we'll just summarize the main findings from S1826. This was the format in the plenary session to start with the main message. So at a planned second interim analysis, the primary progression-free survival endpoint crossed the protocol-specified statistical boundary for our randomized phase 3 trial. And it demonstrated that nivolumab combined with ABD chemotherapy improved progression-free survival compared to brentuximab vedotin combined with ABD as initial treatment of adolescents and adults with advanced stage Hodgkin lymphoma. Nivolumab combined with ABD was well tolerated with few immune-related adverse events observed. Less than 1% of patients on the study received end-of-treatment radiation therapy, which was a huge reduction in the proportion of pediatric patients with advanced stage Hodgkin lymphoma receiving radiation, and I'll explain that more in a second. S1826 was a really key step towards harmonizing the pediatric and adult therapy of Hodgkin lymphoma, and based on these data, nivolumab ABD is poised to be a new standard of treatment for advanced stage Hodgkin lymphoma. So let's take a step back and introduce S1826. And to do that, it helps to set the scene for how we managed advanced stage Hodgkin lymphoma when this trial was designed back in 2018. So for years, PET scan adapted combination chemotherapy had been the standard treatment of advanced stage Hodgkin lymphoma. And you probably remember this from taking your boards and hearing about ABVD and BIACOP and all these regimens that we've used over now decades. But pediatric and adult patients have received different chemotherapy regimens, both globally and in the and in North America, with pediatric patients receiving this regimen called ABV-EPC. And in fact, the majority of pediatric patients received consolidative radiotherapy after their chemotherapy was finished. Globally, adults received different chemotherapy regimens, either ABVD or BIACOP. And there are important limitations to these frontline approaches that we've used for years, including pulmonary toxicity associated with bleomycin, infertility and second cancers associated with the chemotherapy and radiation that we use to cure the disease. And patients who are resistant to their first-line therapy require high-dose chemotherapy and autologous stem cell transplant. For this disease that disproportionately affects the very youngest patients, often in their teens, 20s, and 30s, the morbidity and mortality of curing the disease is high. And this figure illustrates that, long after the risk of Hodgkin lymphoma recurrence plateaus, patients are at increasing risk for late effects from the chemotherapy and radiation that we use to cure their disease. Oops, sorry, you can go to the next slide. Apologies. And you can go to the next slide again. So this slide just shows what I was, what I was discussing, that we basically use different approaches for pediatric and adult patients, including different chemotherapy regimens, radiotherapy. And if you move on to the next slide, again, just showing that long after the risk of Hodgkin lymphoma recurrence plateaus, patients are really at risk for the secondary late effects from the chemotherapy and radiation that we use to cure their disease. Next slide. So just as S1826 was being designed, there was a major change in the landscape of the treatment of Hodgkin lymphoma. Brentuximab vedotin is an antibody drug conjugate directed against CD30 on the surface of Hodgkin lymphoma Reed-Sternberg cells. And several studies demonstrated that incorporating brentuximab vedotin in the frontline treatment of advanced stage Hodgkin lymphoma improved outcomes. The Echelon-1 study actually showed on the bottom left here that brentuximab vedotin combined with ABD chemotherapy improved both modified progression-free survival and overall survival compared to ABVD in adults. And that led to the approval of BV for use in frontline therapy for advanced stage Hodgkin lymphoma. And then subsequently on the bottom right, AHOD 1331, which was a children's oncology group study that showed that brentuximab vedotin combined with AV-EPC improved event-free survival compared with ABV-EPC in pediatric patients. And that led to the approval of BV as frontline therapy for children. Next slide. However, despite the improved outcomes that we see with the incorporation of brentuximab vedotin into frontline therapy, relapses of Hodgkin lymphoma after frontline therapy are still common across the age spectrum. Different chemotherapy backbones are still used for pediatric versus adult patients and globally. A majority of pediatric patients still receive consolidative radiation even when we use that brentuximab. And when it's combined with ABD in adults, brentuximab results in increased toxicity compared to ABVD, including increased peripheral neuropathy and more febrile neutropenia, infections, and sepsis. And that necessitates the use of growth factor, which wasn't necessary with our older ABVD regimen. Clearly, there was room to improve on the outcomes for advanced stage Hodgkin lymphoma when we were designing this trial. Next slide. So the opportunity for a new treatment approach in Hodgkin lymphoma became apparent with the understanding that the biology of PD-1 played a critical role in the pathogenesis of Hodgkin lymphoma. PD-1 ligand genetic alterations on chromosome 9p241, including copy gain, amplification, and even translocations, are common in Hodgkin lymphoma Reed-Sternberg cells. They're ubiquitous, and that leads to overexpression of the PD-1 ligands on the surface of the lymphomas of the Hodgkin lymphoma tumor cells. And the PD-1 blocking antibody nivolumab exploits that genetic vulnerability and was shown to be highly effective treatment for relapse refractory Hodgkin lymphoma with an overall response rate of about 70%. Next slide. So initial clinical trials incorporating PD-1 blockade into the frontline treatment of Hodgkin lymphoma, including nivolumab combined with ABD, demonstrated favorable safety and tolerability with promising efficacy. As you can see evidenced here in this initial study evaluating nivolumab combined with ABD in advanced stage Hodgkin lymphoma. This is the progression-free survival curve after early follow-up, but obviously the results looked excellent. Next slide. So based on this rationale, SWOG led the first ever collaboration between the adult NCTN cooperative groups and the Children's Oncology Group to design SWOG S1826. It's a randomized phase 3 trial where adult and pediatric patients would all be treated with the same ABD chemotherapy backbone at conventional doses, combined with either nivolumab or brentuximab vedotin for 6 cycles in patients with stage 3 or 4 Hodgkin lymphoma, advanced stage disease. G-CSF was required in the brentuximab arm, which that's per the label, and was optional in the nivolumab arm. Patients were randomized in a 1-to-1 fashion, stratified based on age, international prognostic score, and the intention to use consolidative radiotherapy at the end of treatment to residually FDG avid lesions according to a set of protocol-specified criteria. The primary endpoint of the study was progression-free survival with an event-driven analysis based on assumptions of 84% 2-year PFS after brentuximab vedotin ABD and 90% PFS 2 years after nivolumab ABD. Secondary endpoints included event-free survival, overall survival, the complete metabolic response rate at the end of treatment, and patient-reported outcomes. 940 patients were planned for enrollment. Next slide. Abbreviated eligibility criteria for S1826 are shown here. Patients had to have either stage 3 or 4 previously untreated Hodgkin lymphoma. As I mentioned, patients aged 12 years or older were eligible, and there was no upper age limit, unlike prior cooperative group Hodgkin lymphoma trials that incorporated regimens like BIACOP. Patients had to have adequate performance status and organ function to be eligible. Prior pneumonitis, autoimmune disease, or significant peripheral neuropathy were exclusions. Persons living with HIV were eligible. Next slide. So this is a consort diagram for patients enrolled to S1826. The trial accrued in just over 3 years, which was actually nearly a full year ahead of schedule. Again, the trial was conducted primarily during the COVID pandemic, so that was a remarkable achievement in and of itself. There were 994 patients who were registered and randomized to receive either nivolumab ABD or brentuximab vedotin ABD. Next slide. 18 patients were deemed ineligible for the trial, and so 489 patients were eligible and efficacy analyzable in the nivolumab arm, and 487 patients were efficacy analyzable in the brentuximab vedotin arm. Next slide. So a small number of patients were not evaluable for safety, most often because it was too early, and data were not available yet since, as I mentioned, this was an early interim analysis. With 483 patients ultimately analyzable for safety in the nivolumab arm and 473 patients analyzable for safety in the BV arm. Next slide. The baseline characteristics of eligible patients enrolled in the trial are shown here. So a quarter of the patients enrolled onto S1826 were under the age of 18, 10% were over the age of 60. About a quarter of the patients were Black or Hispanic. Next slide. Nearly 2/3 of the patients had stage 4 disease. The majority had B symptoms. Almost a third had higher risk IPS scores. And so overall, S1826 was a truly representative study, not only in terms of demographic, but it was inclusive of patients with high kind of clinical high risk disease relative to modern trials. Next slide. So this figure shows the most common adverse events that we observed by arm in S1826, all grades. As expected with combination chemotherapy, fatigue, gastrointestinal and hematologic toxicities were the most common toxicities that we observed. Next slide. This table focuses on the hematologic toxicities. So as you can see, there was more neutropenia in the nivolumab AVD arm, with a bit more anemia and thrombocytopenia in the brentuximab arm. Now, it's important to note that G-CSF was optional in the nivolumab arm. And so, and as you can see, only about half of patients received it. And so that almost certainly accounts for the higher neutropenia rate. It was basically, this was an expected result. But meanwhile, bone pain related to that growth factor was much more common in the brentuximab vedotin arm, as you can see there. Remember, growth factor is typically not used with ABVD, and severe neutropenia is basically universal with our kind of historical ABVD regimen. Next slide. Now, importantly, there was no increase in febrile neutropenia, sepsis, or infections, despite the increased neutropenia that we saw on the nivolumab arm. So no real functional consequence of that. Next slide. This table compares the rates of peripheral neuropathy, between arms, with both sensory and motor peripheral neuropathy being more frequent in the brentuximab vedotin arm as expected, including a higher rate of grade 3 neuropathy. In fact, when you break this down, most of the neuropathy in the nivolumab arm was grade 1, whereas there was quite a bit more grade 2 or 3 neuropathy in the brentuximab arm. Next slide. This slide shows a range of adverse events of interest across the arms. And as you can see, there was more liver function test abnormality in the brentuximab arm. As expected, there was more hypo or hyperthyroidism in the nivolumab arm, kind of immune-related thyroiditis being certainly a common thing that we see. What we didn't expect, though, was that, in fact, the rates of rash, of pneumonitis, gastritis, colitis, these kind of classic immune-related toxicities actually weren't different between the arms. Next slide. So this is an analysis of just treatment discontinuation and deaths that we observed on the study. There were a few patients at the time of the data cut that we presented at ASCO that were still had treatment ongoing, but most had completed treatment. 12% of patients on the brentuximab arm discontinued all treatment early, all components of therapy, including 7 in the BV arm who had progression or relapse while on therapy, compared to 0 in the nivolumab arm, and 8 in the BV arm who died while on treatment, as compared to only 2 in the nivolumab arm. You can see in the next row that 22% of patients in the in the brentuximab arm discontinued BV, but continued all the other components of therapy, the AVD chemotherapy, whereas only 11% of patients in the nivolumab arm discontinued nivo and continued the remaining components of therapy. Remarkably, 6 patients across the arms, and with the numbers are so small, we're can't really draw conclusions there about radiation according to arm, but 6 patients out of 1,000, nearly 1,000 received radiation, which is a huge reduction in the proportion of patients with pediatric patients, especially who receive radiotherapy. Next slide. So at the second interim analysis, the planned second interim analysis that was performed at 50% of the total progression-free survival events anticipated for the primary analysis, in fact, remarkably, the primary progression-free survival endpoint crossed a very conservative protocol-specified statistical boundary, demonstrating that nivolumab AVD resulted in superior progression-free survival compared to brentuximab vedotin AVD as initial treatment of adolescents and adults with advanced stage Hodgkin lymphoma with their hazard ratio of 0.48, as you can see in the figure. With 12.1 months of median follow-up, the 1-year progression-free survival in the nivolumab arm was 94% compared to 86% in the brentuximab vedotin arm. Next slide. As you can see in this forest plot, the progression-free survival advantage that was observed with nivolumab AVD was consistent across all the subgroups and strata that we observed, that we analyzed, including all age groups, both lower and higher risk IPS scores, patients with or without B symptoms, and was especially notable among patients with stage 4 disease. Next slide. Event-free survival was also superior among patients who received nivolumab AVD with a 1-year EFS of 91% in the nivolumab arm compared to 84% in the rituximab arm. The specific types of EFS events that we observed are shown in the table here on the right, with progression, relapse, and death events occurring more frequently after rituximab vedotin AVD. Next slide. Overall survival is shown here by arm. These data are not yet mature with only 1-year follow-up, but there were 11 deaths observed in the brentuximab vedotin arm and 4 observed in the nivolumab arm. Next slide. So just to conclude, S1826 is the largest Hodgkin lymphoma trial in the history of the North American cooperative groups, the first prospective collaboration between the adult and pediatric NCTN groups. In conclusion, S1826 met its primary endpoint and showed that nivolumab AVD improved progression-free survival compared to brentuximab AVD in advanced stage Hodgkin lymphoma. Nivolumab AVD also improved event-free survival. Nivo AVD was well tolerated with few immune-related adverse events observed. Less than 1% of patients received radiotherapy, which again is a dramatic reduction. A majority of patients, historically with pediatric advanced stage Hodgkin lymphoma have received radiation. So this, was really exciting to see and may reduce long-term late effects of therapy. Follow-up is ongoing to confirm the durability of the PFS benefit, assess long-term safety, overall survival, and patient-reported outcomes. And as I mentioned, this has been a really important step in harmonizing kind of these different ways of approaching pediatric and adult Hodgkin lymphoma that we've had over the years. And based on these data, nivolumab AVD, we expect will become a new standard of care for advanced stage Hodgkin lymphoma. Next slide. I just wanted to thank, of course, the patients, families, caregivers, research teams, our funding sources, SWOG for the opportunity to lead this study, Jonathan Friedberg, our lymphoma group and chair, for the opportunity to partner with him and being the chair for this study. And this trial was really an incredible success due to all of the remarkable collaboration efforts of all the investigators across the CTN and the other in our partner cooperative groups, and has been really exciting in that it sparked ongoing AYA collaboration across the lymphoma committees of the NCTN. So thanks for your attention. Happy to take any questions.
Perfect. I think we're actually going to wrap up in the interest of time, but that was crystal clear. I want to thank our presenters. I want to thank all of our attendees. I hope our Best of SWOG today has convinced you that the group continues to do practice changing, often label changing, now procedure changing work. It's important stuff. Thanks everybody for attending. Have a great rest of the week.